Welcome to part 14 of our Explainer Masterclass series. Today, we're tackling some of the absolute most challenging scenarios you'll face in medical coding, conflicting excludes one notes, and incredibly complex sepsis sequencing. If you're looking to keep your charts completely audit-proof and maintain rock-solid compliance, well, you are definitely in the right place. Let's get started. Let's dive right into the heart of the problem. When coding guidelines conflict and clinical indicators start to blur, how do you determine the absolute correct code sequence? We all know excludes one notes are remarkably strict, but let's be real, clinical reality is messy. A patient can absolutely have multiple intersecting conditions that the tabular list insists just shouldn't go together. So how exactly do we bridge that gap? All right, here's our roadmap for today's explainer. We'll quickly hit transplant sepsis, obstetrical dilemmas, toxic shock syndrome, aspiration pneumonia, and finally wrap up with some crucial CDI compliance takeaways. So let's jump right into Section 1, Transplant Sepsis Case Breakdown, focusing on Klebsiella and the transplanted kidney. Picture this fascinating scenario from the Q4 2023 coding clinic. It's a real brain teaser that tests our grasp on localized versus systemic infections, specifically in highly complex transplant patients. Imagine your provider documents Klebsiella sepsis, present on admission, without septic shock, due to acute pyelonephritis of a previously transplanted right kidney. Think about that for a second. We've got a systemic infection, a localized infection, and a transplant complication all happening at the exact same time. The big question is, what comes first? Well, here is your precise audit-proof sequence. First up, your principal diagnosis absolutely must be A41.59 for that Klebsiella sepsis. Then, you're going to follow that up with your secondary diagnoses in this exact order. T86.13 to capture the kidney transplant infection, followed by N10 for the acute pyelonephritis, and finally N16 for the renal tubulointerstitial disorders. And you know, this perfectly illustrates the ICD-10-CM official guidelines section IC1B4. This rule is a hard stop. It strictly forces the underlying systemic infection, the sepsis, right into that principal diagnosis slot, whenever the patient is admitted for both sepsis and a localized infection. The localized infection, which is our pyelonephritis here, simply gets relegated to a secondary diagnosis. Moving right along to Section 2, Obstetrical and Postpartum Coding Dilemmas, specifically looking at Chapter 15, Sepsis Complexities. Now, Chapter 15 codes for sepsis complicating pregnancy, childbirth, and the riparium. They are notoriously precise and, frankly, pretty tricky. We're talking about codes like 085 for puerperal sepsis and 075.3 for sepsis during labor. So here's a dilemma straight from a real-world coding clinic scenario. We have a 24-year-old patient, 1 week post-spontaneous vaginal delivery. She presents with shortness of breath and a fever due to postpartum sepsis and a postpartum UTI. But wait, the tabular list strictly forbids pairing code 085 with 086.20 because of a pesky excludes one note. So how on earth do we code this? The secret to unlocking this puzzle is all about anatomy. See, code 085 clinically denotes puerperal sepsis, which specifically implies an infection of the genital tract. It absolutely does not mean an infection of the urinary tract. Since our patient's infection is centered in the urinary tract, throwing 085 into the mix is just entirely inappropriate here. To resolve this without breaking that excludes one rule, we just completely bypass 085. Instead, here's what we do. We sequence 098.83 first for the maternal infectious disease, then we drop in A41.9 for the unspecified systemic sepsis, and finally 086.20. Boom. This sequence elegantly and accurately captures both the systemic impact and the localized urinary infection focus. Okay, let's head into Section 3. Toxic shock syndrome and excludes one notes, looking at a retained tampon and sepsis protocol case. Let's dive into this intense emergency department presentation from Q1 2022. A patient rolls in with abdominal pain, chills, a retained tampon, and leukocytosis with a sky-high white blood count of 24. They immediately initiate a sepsis protocol. Ultimately, the final diagnoses are sepsis and suspected toxic shock syndrome, or TSS. But here's the catch. Code A48.3 for toxic shock syndrome and category A41 for other sepsis have conflicting excludes notes. Depending on which note you look at, you might think you need one code, or maybe you need both. So in the showdown, which one actually wins? The answer is actually incredibly simple. We assign only A48.3. But why? Well, it's because toxic shock syndrome inherently captures both the systemic infection and the shock all on its own. It's kind of like a two-for-one deal. Code A48.3 paints the clinical picture so much more accurately than A41.9, making that general sepsis code completely 100% redundant.
All right, moving to Section 4, the aspiration pneumonia dual coding rule, and how we capture both chemical and bacterial processes.
Think about this. How do we capture the complete clinical picture when a patient's sepsis is tied to aspiration pneumonia and is documented as present on admission? For this, we really have to lean on a dual coding rationale. Since the sepsis is present on admission, step 1 is sequencing the systemic sepsis, A41.9, as your principal diagnosis. Easy enough, right? But for the pneumonia itself, you have to remember that aspiration is a chemical effect, whereas sepsis requires an infectious process. Because of that distinction, you absolutely need both J18.9 to capture the infectious bacterial pneumonia and J69.0 to capture that chemical aspiration process. You need the whole shebang.
Finally, let's wrap things up with Section 5, CDI compliance takeaways, and how to go about audit-proofing your charts.
We've walked through some seriously technical sequencing rules today, but how do we make sure our charts actually survive an audit? The bedrock of our entire practice is ICD-10-CM section IA-19. Lock this rule into your memory. We code based on the provider's explicit diagnostic statement that a condition exists. Period. Code assignment is never, ever based on our own independent interpretation of the clinical criteria the provider used. We aren't the ones diagnosing. Our job is to translate their documented statements into codes. At the end of the day, compliance is a team sport. It requires a joint effort between the provider and the coder. You've got to validate those clinical conditions before you ever drop a code. And honestly, this is the most crucial part. If a practitioner documents a heavy-hitting diagnosis like sepsis, but the clinical indicators in the health record just don't back it up, you have to query that provider or escalate it immediately. Don't just guess. By mastering these coding clinic directives, you're making sure your documentation is completely ironclad. Ask yourself right now, are you leaving revenue on the table, or worse, basically inviting an audit just because of a misunderstood excludes one note? Stay tuned for part 15, where we conclude our masterclass with CDI and audit defense, navigating sepsis 3-payer denials, the best practice query workflow, and revenue integrity. Until then, keep learning and keep leveling up. This is Decode Healthcare with Harshal.